and can go to the next talk. It is a recorded talk by Dr. Najjar, who is another member of the melanoma program, and Yana is going to talk about the impact of the COVID pandemic in melanoma.
Hi, my name is Yana Najjar. I'm one of the melanoma medical oncology physicians here at the UPMC Hillman Cancer Center and the director of the Clinical and Translational Research Center. And I'll be speaking to you today about what I think is a very timely topic. So we'll be talking today about the impact of the COVID-19 pandemic on staging for patients with invasive melanoma. These are my disclosures, which do not impact my presentation today. The incidence of melanoma has unfortunately continued to steadily increase through the last several decades. It is the fifth most common cancer seen in the US in both men and women. And I like the graphic on the right-hand side because it shows you the kinetics of increased incidence over time. So you can see that in the 1980s, we were down here for men and women, and the slope has continued to go up quite steeply, and it continues to do so today. When we think about the incidence that's projected for 2022, we expect to see close to 100,000 new melanomas diagnosed this year and almost 8,000 deaths. Now, one thing to understand is that prognosis is fundamentally related to the stage at presentation. And what do we mean by that? So all of our patients recall us talking about the Breslow thickness. That's probably the first thing we talk about when we try and get a sense of how a patient is going to do long term. And what that is, as you can see over here on the left-hand side, it's a measure of how invasive the tumor is from its surface in the epidermis down to its deepest point. And there are several stages up to T4, and these directly feed into outcomes. Another thing I will say is that ulceration is also fundamentally linked to outcome. And ulceration is a pathologic feature, meaning when we look under the microscope, we see whether or not the epidermis or the skin surface overlying the tumor is intact. If it is, then the tumor is not ulcerated. And if it is, then the tumor is ulcerated. And we understand that ulceration is associated with a more aggressive phenotype of melanoma. And so what I want to show you over here is that for every T stage with increasing thickness, the survival probability goes down at 5 and 10 years. And I'll also draw your attention to the fact that with increased incidence of ulceration, that upticks a patient's prognosis. Meaning, if you have a thicker melanoma, your outcome is likely to be worse from historical data than if you have an ulcerated melanoma that is also associated with worse outcomes. And this is reflected in the HACC 8th edition of staging. Furthermore, the T stage, in addition to the presence or absence of melanoma metastases in the sentinel lymph node, feeds into the overall stage. So stage 1 and 2 are when a melanoma is limited to the skin. Stage 3 is when a melanoma has moved to a lymph node. And you can appreciate here in green, this is stage 3A all the way up to stage 3D. These are more heavily involved lymph nodes with or without the presence of what we call satellite lesions, meaning melanoma that's on the move within the skin. But the point I want to make to you here is that with increasing stage 3, the melanoma-specific survival probability decreases, which is probably intuitive. Now, this is a study that I wanted to share with you coming out of the UK soon after the pandemic began. And this showed us that there was a significant increase in anticipated cancer-related deaths as a result of the COVID pandemic. And what they did was to pull almost 70,000 cases of various malignancies. They focused on the 4 subtypes that we see here: breast, colorectal, lung, and esophageal. And they performed some modeling to anticipate the outcomes, how the outcomes would be impacted by delays in care. And they modeled scenario A to scenario C. So these are their best case to worst case scenarios with an intermediate scenario B. And without getting into all of the details in the interest of time, I will draw your attention to the fact that there was a significant increase in the number of deaths at 5 years for every one of these malignancies, again, because of delays in care. They estimated up to 3,600 deaths within 5 years. And when you think about that in terms of years of life lost, which is how they conclude their paper, it's a pretty staggering number at over 63,000. We've also seen a decrease in melanoma diagnosis and in patients coming to attention from dermatology and medical oncology during the pandemic. So this is a study that came out of an Italian group, and there have been similar studies elsewhere. You can see that in the pre-pandemic era, 2.3 melanoma diagnoses were being made a day across dermatology clinics, whereas during and post-pandemic, perhaps I should say during the pandemic, since it's not yet over, we're at 0.6 melanoma diagnoses per day. And in the United States, dermatology practices have seen less patients. This has been widely published in the literature, and there is a decreased number of biopsies being performed. We wanted to address this issue head on in our own practice. And so what we did was to perform a retrospective analysis in order to evaluate the impact of the COVID-19 pandemic at a large tertiary care center here at the UPMC Hillman Cancer Center. We evaluated 246 patients between March 11th, 2020, which was the beginning of the pandemic as announced by the WHO, with a data cutoff of January 12th of 2021. We then matched this cohort with 246 patients treated between March 1st, 2019 and March 10th, 2020. So we had 246 during COVID and 246 just prior. These are the patient characteristics. You can appreciate that in the pre and post-pandemic cohorts, they are well balanced for age, a median age of 65 for both. As is typical for melanoma, you see a higher incidence in men than in women. Again, balanced across the two arms. The majority of patients had self-identified as white, and there was very low numbers of Black or other races identified, which is something that we see because of where we are located geographically, but also because of the type of disease we're dealing with, which in this case is cutaneous melanoma. We did note that there were higher risk pathologic features noted post-pandemic compared to pre-pandemic. I'll draw your attention to the Breslow Depth, which is where we began talking earlier about this being the most important factor, or rather the first factor that we look at when we start to stage and think about prognosis. And you can see that the median Breslow depth, the invasiveness of the melanoma, was 1.4 millimeters in the pre-pandemic versus 2.0 millimeters in the post-pandemic. And this was a statistically significant difference as well. We saw a trend towards increased ulceration in the post-pandemic cohort, though this did not reach statistical significance. But there was a numerically increased number of patients with ulcerated versus non-ulcerated melanoma. We also saw a significantly increased number of patients who had a higher mitotic rate, meaning more patients had more melanoma cells actively dividing under the microscope on their biopsy specimens in the post-pandemic than the pre-pandemic. The mitotic rate does not feed directly into the HACC 8th staging edition, which is what we use now. I think many of us anticipate that that will come back in the next iteration, but the point I'm trying to make is that mitotic rate is understood to be a poor prognostic factor if it's high, and we did see it go up in the post-pandemic cohort. We saw trends towards increased perineural invasion and microsatellites in the post-pandemic cohort, but these did not reach statistical significance either. Now, this is where I think it gets really interesting, and something all of us, I think my partners and I had all intuited just continuing to treat melanoma during the pandemic. We had the general sense that we were seeing less early stage melanoma. And when we actually looked at the numbers, that turned out to be true. So in the pre-pandemic era, of the 246 patients, 41%, 100 patients had stage 1 melanoma. Whereas in the post-pandemic cohort, only 29% or 70 patients had stage 1 melanoma, and that did reach statistical significance. So you can appreciate that if a patient is diagnosed with melanoma during COVID, they are less likely to have stage 1. And that's probably because they're coming to medical attention through dermatology and eventually coming to see us later than they would have otherwise been. We also saw that more patients were diagnosed with stage 3 melanoma during the COVID-19 pandemic. So 21% pre-pandemic had stage 3 disease, which typically means they have nodal involvement. Otherwise, they have satellite or in-transit lesions. Whereas in the post-pandemic cohort, 31%, 10% more, had stage 3 disease. And again, you remember that stage 3 disease is associated with significantly poorer prognosis in stage 1. And so these findings certainly have clinical implications. What about sentinel lymph node biopsies during the pandemic? So generally speaking, any patients with a melanoma that's 0.8 millimeters Breslow or more is recommended to undergo a sentinel lymph node biopsy in addition to their wide local excision. We found that most patients in the pre and post cohorts who were recommended a sentinel lymph node biopsy did undergo one. Sentinel lymph node biopsy was foregone in only 4 patients, and these were patients who either became ill with COVID, and by the time they came back to the OR, or by the time they got to the OR, it was decided that a long time had passed and to simply proceed with wide local, otherwise due to delays in scheduling, but that was only 1 patient. So you can appreciate that in spite of there being staffing issues and shortages, et cetera, which you're all very well aware of, we certainly continue to operate per standard of care, recommending and performing sentinel lymph node biopsies when appropriate. During the pandemic, 38% of patients who underwent a sentinel lymph node biopsy came back to have nodal involvement, versus in the post cohort, versus in the 38% of patients in the post cohort were found to have melanoma in the sentinel lymph node versus close to 30% in the pre-cohort. So if you're undergoing a sentinel lymph node biopsy during the pandemic, you are more likely to have sentinel lymph node involvement. And that is why you see a higher number of stage 3 patients, as I had shown you a couple of slides ago. It's because of these more likely involved lymph nodes during sentinel lymph node biopsy that you see an uptick in the diagnosis of stage 3 melanoma. What about with metastatic disease? We did not find a significant difference in the number of patients with a new diagnosis of stage 4 disease in each arm. However, we found a significant increase in patients who are presenting with metastatic recurrence in the post cohort compared to the pre-cohort. So 7.7% of patients in the pre-cohort had a metastatic recurrence. 7.7% of patients in the post cohort had a metastatic recurrence versus 3.3% in the pre-cohort. And interestingly, for patients with metastatic recurrence, the median time to recurrence from the time of initial melanoma diagnosis more than doubled in the post cohort, so 25.5 months to 60 months. While this did not reach statistical significance, I would argue that it is clinically significant. And some of the statistics here are driven by the smaller numbers that you have. So we have more numbers of patients in stage 1, 2, 3 versus stage 4. And I think that's why we're not seeing statistically significant numbers, though we think some of these are clinically significant, as I mentioned. Furthermore, we found that 6.5% of patients in the post-pandemic had brain metastases, compared to 1.6% of patients in the pre-pandemic. This, I think, is a very concerning finding because brain metastases are well understood to very unfortunately be a terrible prognostic marker in terms of how our patients do long-term. Now, fortunately, we're in the era of very active immunotherapy, but historically, this has been a real problem. And so the fact that you're seeing a jump from 1.6 to 6.5% brain mets is really very concerning. What about trends in treatment? So at our institution, patients undergoing adjuvant therapy were more likely to receive targeted therapy than they were to receive immune checkpoint inhibition in the pandemic era. Now, what I mean by adjuvant therapy is when tumor is resected and we're treating for a year to try and decrease the likelihood of metastatic or local regional recurrence. Targeted therapy is taken orally. These are pills patients take twice a day, every day. Whereas immune checkpoint inhibitors are IV treatments. Patients come in and they get an IV and they're in the treatment area. It's a lot more healthcare interfacing from the patient's side. And so I think you can see here that our appetite for bringing in patients really was decreased during the pandemic. If we could spare patients trips to the treatment room, we really tried to. And so we saw more targeted therapy during the pandemic than we otherwise saw compared to adjuvant therapy. We did not see the same difference in metastatic therapy. And I think that's due to two things. I think when a patient has metastatic disease, we tend to favor treatment with upfront immunotherapy, and that has really been the case for some time. Most recent data has really convinced us that this is the way to go. But I also think in the metastatic setting, we are more apt to do what we think we have to do, and we're less likely to make any sort of compromises. Not to say that targeted therapy in the adjuvant setting is a compromise, but it's to say that if we could spare patients the trip in the adjuvant setting, we did, whereas in the metastatic setting, I think we just get on with it and do what we think we have to do. So in conclusion, these data highlight the importance of continued routine total body skin exams for early detection of melanoma. Delays in care are associated with higher stage melanoma, as I have shown you, and alarmingly, more brain metastases. We did not reach the median progression-free or overall survival. We don't yet have that follow-up time, but I have no doubt that when we come back and look, we will see a higher incidence of death related to melanoma during the pandemic compared to before, even accounting for changes in therapy. Timely oncology referral for patients with melanoma remains critical even during the pandemic. And with that, I thank you for your attention. I'm sorry I'm not there in person, but please don't hesitate to reach out to me if you have any questions whatsoever. I would like to thank our patients and their families. This study is an excellent example of how we use our 9699 tissue and biobanking protocol. It also allows us to look at long-term outcomes. My melanoma team and Saba Sheikh, who is one of our excellent fellows who really spearheaded the collection and analysis of data for this project. Thank you.